I am Dr. Malik. Today I want to talk about my subject, that is anesthesia. I have done my MBBS from Gandhi Medical College, Hyderabad, diploma anesthesia from Gandhi Medical College, Hyderabad, 2 years, and then I have done my MD anesthesia from Osmania Medical College, Hyderabad. So I have done anesthesia for 5 years, total 5 years. So after MBBS I have done 5 years anesthesia. Why? So when somebody asks me, what are you as a doctor? So I say, I'm an anesthetist. So they say that, okay, some people, they don't have, some people who underwent anesthesia, who have taken anesthesia, who have undergone surgeries, they may know a little bit. But common man, even intellectuals also, they don't know much about anesthesia. So what they do is, I think you give an injection, some dose related injection and go, is it? Some anesthesia injection and just you go after giving it. This is what you do. Or even one of the chemical engineers, he asked me, I think you give a tablet, anesthesia, some tablet and go away. See, these are some misnomers which people are having about anesthesia. So I want to tell you what is an anesthetist, what is anesthesia. So first of all, anesthesia. Anesthesia, what is the literal meaning of anesthesia? Anesthesia means a stage of knowing nothing. A stage of knowing nothing. That means you are giving anesthesia to a person. So before surgery, so the surgery or any procedure, whether it is surgery or any procedure, the particular person doesn't have any senses or any knowledge of what is going on. That is the thing. No pain, absolutely pain-free, and he doesn't have any knowledge of what is going on his body, what is being done to his body. That is called, a feeling of knowing nothing is called anesthesia. So nowadays, previously when anesthesia was started, it was only anesthesia and anesthetists were confined to only operation theaters. But nowadays in the sense, for the last 20-30 years, almost I can say that, anesthesia is included. Anesthesia has been given another task of intensive care unit, that is critical patient management. So critically ill management, critical management also, intensive care unit management, critical care, these two are added to anesthesia. So anesthetist works in OT, in ICU, in OT is operation theater, ICU, ICCU, intensive cardiac care unit, and casualties, emergencies, and AMC, acute medical care units. And nowadays, anesthetists have extended themselves for the last 10-15 years to pain clinics also. That means chronic pain, acute pain, whatever pain it is. A patient suffering from pain, from chronic pains usually, they can directly approach the anesthetist for pain relief. Usually people go to neurophysician, they have a very good knowledge, and nowadays even anesthetists are also trained to treat the chronic pains, okay, and recurrent chronic pains. Pain clinics are run by nowadays anesthetists. So the young boys now who are coming out of anesthesia, the subject, who have done the subject, so they are asking me, shall we go for pain clinic speciality, pain speciality? Yes, it's a very good subject, because pain is one thing which every human being feels, and some people are suffering with pain. Some people commit suicide also, not tolerating pain. Such pains they can tolerate, they can easily. An anesthetist who is trained in exclusively pain, he can easily manage the pain. So that is one thing. One more thing is, what is the difference between anesthetist and anesthesiologist? Anesthetist is a technician. After completing his plus two, some people do 3 years anesthesia technician course. They are called anesthetists. Anesthesiologist is somebody like me. After completing MBBS, we do MD 3 years, or diploma and MD 5 years, like that. So we are called anesthesiologists because we thoroughly go through the subject, including the basics. So, how many types of anesthesia are there? Number one, anesthesia is broadly general anesthesia, that is given to full body. Regional anesthesia, only particular area. For example, see, there is a broken arm. So only anesthesia to the limb. That can be done. Regional anesthesia. Local anesthesia means, for example, you have a cut injury here. Only we give some local anesthetic here. Some xylocaine or sensacaine. There are local anesthetic drugs. We give local anesthetic here and suture it. Or you have some injury to the finger, we give anesthesia here called block. It's also called local anesthesia. And sedation. Some cases you need sedation. For example, you are doing dressing for burns cases, or you are doing a colonoscopy, or you are doing a endoscopy. The patient is not tolerating it, so we give sedation. That is called short general anesthesia. Short general anesthesia is also a part of this, because these are all varieties of anesthesia we give. And particularly now, first we go to the regional anesthesia. They are called exclusively blocks. Blocks means you give block to the hand. That means there are nerves which are going from the brain, from the neck to the upper limb. So we block them here. Giving a local anesthetic, that is lignocaine or sensacaine, xylocaine or sensacaine here, and we give that quantity which is sufficient for this particular surgery. So they are called blocks. And not only hand, to all the parts of the body. There is one more thing called spinal anesthesia. We all know that we are going to inject a small drug into the spinal cord, into the cerebrospinal fluid which is flowing in the spinal cord. We inject the drug into the cerebrospinal fluid. This is called spinal anesthesia. From the navel below, everything will be anesthetized from the navel below, because both the limbs, both the legs up to navel are completely anesthetized. So this is called spinal anesthesia. One more variety in spinal anesthesia is epidural. Here we are not going to inject the drug into the cerebrospinal fluid. In the spinal cord, we are not going into the cerebrospinal fluid. We are depositing the drug in one space called epidural space. That is just one layer above the cerebrospinal fluid. So that will be absorbed by the nerves, and the final effect will be just like spinal anesthesia. So you can do any leg surgeries, you can do any abdominal surgeries like hysterectomies, appendectomies, appendix, and any leg fractures or whatever it is, we can do it. So this is blocks. And let us, we all know about local anesthesia and sedation. It is very simple, so we need not talk about it. Now we'll come to the general anesthesia. General anesthesia is a big subject. It has got 5. See, for general anesthesia, for giving general anesthesia, we need a machine called Boyle's machine. Nowadays we call it anesthesia. We call it anesthesia working station. Because it has also got ventilator in it. So what does this Boyle's machine? Why it is named as Boyle's machine? Because it is named as Boyle's machine because Sir Edmund Gaskin Boyle, he has invented that machine. This machine delivers oxygen, nitrous oxide. Nitrous oxide is also called laughing gas because it is a painkiller, and one or two drugs called, they are inhalational anesthetic agents. They are liquids, but they turn into gases. They are put in vaporizer, and that vapor is going to that gas is going to that is a liquid which turns into gas, which is going to the patient. That called inhalational anesthetic agents. So oxygen, nitrous oxide, and one more inhalational anesthetic agent. So three agents are being supplied by the machine. So that is called Boyle's machine or anesthesia working station. Anesthesia working station has got a monitor. It has got a monitor which shows, it is called pulse oximeter or multi-para monitor, which shows your BP, which shows your ECG, which shows your pulse oximeter, that is how much oxygen is there in the body, everything. You know about the pulse oximeter. It shows the heart rate, it shows the oxygen which is present in the body by knowing the color index of the heart. So it has got 5 stages. General anesthesia has got 5 stages: pre-medication, induction, intubation, maintenance and reversal. In pre-medication is given even before going to the operation theatre. So usually we give the patient some a narcotic, an antiemetic set, that is to control vomiting. We give some ondansetron or perinorm, and we give one narcotic, for example fentanyl. This is to reduce his anxiety and pain relief, anxiety, everything is reduced by narcotic by name fentanyl or sufentanil, alfentanil. So many drugs have come up. These drugs are different from the narcotics which are usually abused by the youth and all. These are different. This is called fentanyl. These are injections called fentanyl, sufentanil, alfentanil. There are multiple injections like that, narcotic injections, but they are used in medicine, in anesthesia. They are used in anesthesia. Okay, and then we take the patient into the theatre. Then we induce the patient. We start giving oxygen, and we put the patient into sleep by a drug called propofol. This is called induction agent. Propofol, I think you must have heard about this drug, white drug. I think Michael Jackson, people say that Michael Jackson is the man who died because of propofol, overdose of propofol. I don't know how much it is true, but it was found there when he's dead. It is very safe as long as it is given by a doctor, an anesthetist. So we give him propofol, put him into sleep. Next is the patient is now completely sleeping, and his breathing also reduced. He is not able to breathe also, completely anesthetized. Then we have to take completely we have to take the patient into our hands. We do intubation with this is called endotracheal tube. We'll put in this tube into the lungs, into the trachea with laryngoscope by giving one muscle relaxant. This is choline, succinylcholine also. It is called succinylcholine. It is a depolarizing muscle relaxant, choline. So this is the endotracheal tube we use. We put into the larynx, we put into the throat of the patient, into the trachea of the patient, and we start giving oxygen, nitrous oxide, and inhalational anesthetic agent from the machine, from the Boyle's machine or anesthesia machine. So this particular choline is used to completely relax the patient. There are some misnomers about this choline. There is it is true that choline should not be given to Vaishya community and Jews, because Vaishya community, not all, 1 among 10, 1 in 10 or something like that, they respond very badly to choline. That means they don't come out of choline. They come slowly, because the enzyme which is there in the body to hydrolyze, to destroy this choline, to hydrolyze this choline is deficient in that particular community, Vaishyas or Jews. So not everyone, very few of them, one out of 10 or 1 out of 20 like that. Then it is not dangerous. We ask the patient whether you are a Vaishya, and then we can avoid this drug, we can go for some other drugs, but this is a safe drug. After giving it, by chance the patient is not coming out, You know that the patient has got some problem with the enzyme which inside. So you can do only simple. You can put the patient on ventilator for some time. The patient will come out. Or you can do one thing. You can give some 100 ml of blood transfusion from a different person, not from the family people, not from the family, from a different person, same group, 100 ml. For example, I send my technician to the blood bank. I ask him to give 100 ml of blood and just transfuse. It will have the enzyme, just give it. So simple. It is not that dangerous. Okay, there is nothing. It is not life threatening. It is not life threatening. So intubation is over. Now the patient is under our control. The patient is under our control. Next is the maintenance stage. During the maintenance stage, we give them long-acting muscle relaxants like vecuronium, atracurium. These are non-depolarizing muscle relaxants. As long as the surgery is going on, the patient should be completely relaxed, because he should not be tight, isn't it? Completely muscle relaxant. You should give painkiller, analgesic. We go on giving fentanyl, that is narcotic, small doses at frequent intervals, and oxygen, nitrous oxide, inhalational anesthetic agent. We put the patient into deeper planes, and the monitoring is compulsory. The patient is monitored throughout the surgery. The patient is monitored throughout the surgery. How is the BP? How is the ECG? X, everything. So these are very, very safe. And last stage comes once the surgery is over, is reversal. Reversal means these muscle relaxants, we have to reverse them. We have to reverse them. That means you have to take them out from neuromuscular junction. So there is one drug called neostigmine, which reverses the actions of this muscle relaxants. So we give that drug, and we bring the patient out of anesthesia. We slowly discontinue all the drugs. Last, we give only oxygen for about 5 minutes or 3 minutes, and take out the tube. We take him to ICU. We take him to ICU or post-operative ward. 99.9999% safe. So usually in anesthesia, very rarely problems occur. Problems occur with already patients with, but we take all the precautions. For every patient problem, we have anesthesia. We are giving anesthesia to even dying patient naturally, because whatever we have to do till the last. We have to try till the last. Anesthetist is not only doing this, he is working with ventilators. He is working with ventilators in ICU and acute medical care. All the emergencies like snake bites, organophosphorus poisonings, what are all the things? People come after they're doing some suicidal attempts, traffic accidents. All these things, the anesthetist is involved in every subject, including the dental, because dental surgeons, facial-maxillary surgeons and all, or even other dental surgeons for extracting teeth in children or uncooperative patients, or face surgeries, facial-maxillary surgeons do it. We are the people who give anesthesia. There is no separate anesthetist in dental practice. We are the people who go for anesthesia for even dental subject also. Even dental practitioners who are doing facial-maxillary surgery, we are the people who are called. My children are facial-maxillary surgeons. I am the anesthetist for them. This is the thing. So anesthetist is not different for dental practice and medical practice. Anesthesia is only one. And these are all the things. There are so many things to be done. And one more thing. Since long time, almost 30-40 years, we are doing is painless labor. Painless labor is also done by gynecologist and anesthetist combination. Painless labor. If a girl wants to have a painless delivery, not cesarean sections, painless labor, normal delivery without pain, that is called obstetric analgesia. Painless labor also is done by anesthetist, and this epidural anesthesia is the this particular thing is applied there. into the epidural space in the spine, we introduce a small tube, very small plastic tube, and go on giving small doses of injections whenever there is pain, or the patient is knowing the pain. So this particular epidural analgesia, epidural anesthesia for obstetric labor, that is for patients who are undergoing labor, it is very effective. Here the gynecologist and the anesthetist just round the clock stay with the patient till the delivery is over, and this is in combination. Both we do the pain part of the thing, and delivery part is taken by the gynecologist. So usually this painless labor is called obstetric analgesia, painless normal delivery. Now this is also being done. See, there are so many things done by anesthetist. Now anesthetist is an important part of critical care, and critical care is under anesthesia. So the days where he was only in operation theatre are gone. Now he has become a regular part of critical care and medical care. We are in pediatrics. We are helping pediatricians, we are helping medicine people, we are helping all the varieties of surgeons, including dental surgeons. So luckily our part is very big. So that is the reason I stay round the clock in the operation. Now round the clock in the hospital, I stay in the top floor of my hospital, and round the clock I am here to give services. So please.